for coming and listening to us talk about the healthcare system. It's a topic I'm very passionate about. I'm going to talk to you about, is that better? Okay. I'm going to talk to you about some work that I've done over the past couple of years with Dr. Wright. He's an associate professor at the University of Toronto, and he really spearheaded some of this work that I'm going to be speaking about today. So before I get into the meat of our work, I'm just curious with a show of hands, out of everyone who's here today, who's concerned about the sustainability of our healthcare system? Okay, so that's probably the majority of our probably biased sample, but that's great. And how many of you in the past year, or even beyond the past year, have provided informal care to someone that you love, who's a family or a friend? Yeah, so a lot of you. How many of you have received public health care? And how many of you pay taxes? So you can see that we should all care because we have a vested interest in healthcare in terms of the financing and the sustainability of our healthcare system. So for the next 10 minutes or so, I'm just going to talk to you about why you should care as taxpayers and as potential users of the healthcare system. So two basic reasons why I think we should have an interest in this topic. So the first point I'm going to talk about is why should you care as a taxpayer? So our healthcare system is very costly. In 2016-17, the Ontario budget has been set for just under $52 billion for healthcare, which is about 40% of the overall budget. So it comprises a substantial portion. With inflation of salaries and increasing pressures on the healthcare system with an aging population, you can appreciate that we have to do more with less cost. Hospital budgets are becoming increasingly fixed, putting more strain on hospitals to basically not incur any deficits. So there's a lot of pressures that are going on with the healthcare system. So what does the distribution of the healthcare look like, and what does the concentration of healthcare spending look like? So we know that healthcare spending is very much skewed, and we know this since the 1950s, really. We've known that very small proportion of the population occurs the largest proportion of healthcare costs. And my colleague, Dr. Wright, had identified this in Ontario with 5% of the population costing about 65% of healthcare costs. So again, a very small proportion of the population is costing a very large amount. So in a recent paper that Walter had published in the Canadian Medical Association Journal, which was just published in January, he was really interested in looking, and his team were really interested in looking at the concentration of healthcare spending over time and by age. So basically, if someone was a high-cost user in 1 year, so say the top 5%, would they be high cost in the following years? And how does this vary by age? So they used administrative data at the Institute for Clinical Evaluative Sciences, and which is also called ICES. And at ICES, they hold health data for publicly funded services. So Walter basically identified all healthcare encounters within the public for Ontario and assigned costs basically to healthcare encounters. And so what did they find? They found that basically individuals who were identified in a high cost group, so the top 5% in 1 year, so in 2009, were also high cost in the following year, and this was slightly less than about 50% of that cohort was also high cost in the following year. They also found that about a third of the people identified in high cost in 2009 were also high cost for the overall 3-year period. So there's consistency in high cost use of the same individuals. They also found that the lowest cost group remained lowest cost. So people who didn't cost a lot to the system remained lower in the lowest cost group for over a 3-year period. What they also found was that the threshold of spending very much varied by age, such that the older adults, so individuals over 65, had the highest threshold, which was over $45,000 to be in that highest top 5% group. And children, not surprisingly, only had to have $2,300 spent within that year to be part of the top 5% high cost group. So So there's a lot of variation by age, which makes sense because we know our older adults have a lot of multimorbidity and complex needs. So what are the takeaway points from Walter's work? So there's modest stability and consistency of high cost use over time. So if somebody has been identified as a high cost in the top 5% in 1 year, they're more likely to be he identified that they're likely to be high cost in following years. And so this is actually an opportunity for an intervention, because if we can identify those folks, then we can potentially intervene and do something about it. But it probably requires a dramatic shift in our thinking about how we deliver services. And importantly, in order for us to do anything, we have to understand a little bit more about who are these individuals. So that's where some of my work comes in. So this leads me to my second point of why we should care, because we are potential high-cost users of the healthcare system, and it's important for us to know what are the reasons for our costly interactions with the healthcare system. So building on some of Walter's work, we are very much interested in trying to understand more why there are high-cost use and what are the main reasons for these episodes of care within the healthcare system. So what we did was we identified the top 5% high-cost users in the fiscal year 2010 and 2011, and we identified individuals who were living in the community at the very beginning of that fiscal year, which was about 600,000 individuals in Ontario. And then we went back to the very beginning of that fiscal year, and we tried to map out basically the interactions within the healthcare system. So what were the main reasons for the 600,000 individuals interacting with the healthcare system? So we had to create some algorithms and assumptions within our episodes of care, and we started that with an episode with an acute care admission to the hospital. And this is based on previous research, which we know acute care is one of the most costly reasons for interacting with the healthcare system. So we started an episode with an acute care, and we continued an episode of care until people were discharged into the community for 30 days without any further institutional care. So if I was admitted to acute care, say in a downtown hospital, and I was transferred to rehabilitation in an inpatient setting, and I went home, but within 20 days of being home, I had a complication, and I bounced back into acute care, my episode would continue until I had 30 days without any further institutional care. So this is the assumption that we made when creating these episodes. And we created different categories for these episodes to try to understand the reasons for healthcare use, and this was based on some previous work that we had found in the United States. So we created 13 kind of broad categories of reasons for use, which included pregnancy, low birth weight, mental health and addictions, trauma, injuries, poisonings and accidents, planned medical and surgical, unplanned medical and surgical, and cancer, and we had another bucket. If we couldn't categorize anyone into the previous categories, we had another group. So what did we find? Well, after many years of pulling our hair on these algorithms, we were very happy to have allocated 70% of the high cost into some meaningful category within these episodes. And I'm just going to talk to you about the top 5 main reasons in the episodes that we identified, which were over $1 billion for 1 year, between 2010 and 2011. So the top cost group was related to what we called post-admission events. So these were things that occurred in the hospital related to post-op complications, mainly due to orthopedic devices, cardiac complications with grafts and implants. And this cost in 2010 to 2011, that fiscal year, $2.7 billion. In second place, we found unplanned medical events were costing $2.5 billion between 2010 and 2011. And these were mainly due to heart attacks and stroke. In third place, we found planned surgeries to be the third big top cost driver at $1.9 billion. And these were mainly due to hip and knee surgeries and cataract surgeries. And in fourth place was mental health and addictions at $1.3 billion. And these were events related to dementia, delirium, depression, anxiety, schizophrenia. And in fifth place, we had trauma, injuries, accidents, and poisonings at $1.2 billion, and they're mainly due to hip fractures. So overall, we took from this that we can really see how costs shift based on volume and the cost per episode. It's simple math when you break it down into that algorithm. And we found that certain categories actually were very low in volume, but high in median cost per episode. So some of those categories would be mental health and addictions and trauma, for instance. So we saw, relatively speaking, lower volumes, but the cost per episode was substantially high. What we did see with planned surgeries was that the volume of planned surgeries were really high, but the cost per episode was relatively low. But overall then, the cost still shifted to be overall high because of the volume. So this is important for us to appreciate as a public, because we want to be able to appreciate where are the pressure points on our healthcare system. And with an aging population where we see dementia, we might have increased risks of hip fractures. We might have more demand for planned orthopedic surgeries. These are things that we need to be prepared for, because we might be seeing an increased demand and pressure on our healthcare system. So in summary, our work has sort of identified some hot spots, basically where we can identify certain population groups that might be driving health system cost and potential for improvement. So if we just take a basic kind of math exercise, if we reduced post-acute admission events by 35%, we could potentially be saving up to $1 billion in a year. That's a substantial amount of money. There's a lot of assumptions, obviously, that we're making within this, but it just raises us to think about how can we probably improve efficiencies within our healthcare system and quality of care. If we think about planned surgeries, for instance, with hip and knee replacements, is this being driven by consumer demand? Can we provide care in different modalities? I'm a physical therapist by background, so I know I'm biased, but I think about, can we provide physical therapy services and maybe offset some of these surgeries that might not necessarily be needed. With unplanned medical events, we know we have increasing multimorbidity in our population. Our population as a whole is not as healthy. How can we think about public policy like the built environment, social determinants of health? How can we have a healthier overall population so we're reducing some of these unplanned medical events? And with mental health and addictions, I think it's common knowledge now that we're lacking services in the community for mental health and addictions. And again, it's an opportunity for us to think about how can we increase services in the community to offset the demand in acute care. So these are just a very few examples of why I think we should care as taxpayers and users of the healthcare system. I think there's a growing awareness that there's a rising tide of pressure points on our healthcare system. With an aging population, we have multimorbidity. And I think it's a critical point in our healthcare system that we need more public voices. We need more discussion like this to talk about how can we better provide our healthcare services, what type of services do we want funded, and how do we want that delivered. And we really need innovation and opportunities to have efficiency within different healthcare sectors, within acute care, within the community, and breaking some of the silos that exist across the sectors. Thank you.